Hi everyone, for this minute video, I'm going to go over step one style multiple choice questions related to the thyroid. So normally when I approach a question, I usually like to read the last sentence first and look through the answer choices to see what category I'm working with. But since all of these questions will be related to thyroid, I will skip that part. So I will just read the question directly. A 29-year-old woman presents with 3 months of palpitations, heat intolerance, and intermittent painless swelling of the anterior neck. On exam, she has a resting tachycardia at 110 beats per minute, a fine tremor, and a smooth, mildly enlarged thyroid without tenderness. Labs are TSH is less than 0.01, free T4 is 4.1, and T3 is 340. Anti-TSH receptor antibodies are positive. Radioactive iodine uptake is diffusely increased. She plans pregnancy and asks about definitive therapy. She is concerned about future fertility and fetal risks. Which choice best balances efficacy and reproductive safety for definitive management now? So after I read the question stem, I like to take note of key lab values or keywords, which I have identified here in red. And if there's a lot of information like this and I don't want my entire question stem to be highlighted, I like to take little notes on the side. So here it's consistent with a hyperthyroid state based on her symptoms. And she has a low TSH with a high T4, T3. She also has a positive anti-TSH receptor antibody and also increased iodine uptake. All of these which point to Graves. So now that I know that the likely diagnosis is probably Graves, then I will read through the answer choices and go through a process of elimination. So the first thing I wanted to eliminate was E, continued watchful waiting without therapy, because untreated Graves risks maternal and fetal complications, and it's not an acceptable definitive plan when she wants pregnancy. Next, I wanted to eliminate D, which is high dose propranolol alone until she conceives. Although a beta blocker like propranolol will control her symptoms like her tachycardia, it does not treat the underlying hyperfunction and it's not a definitive treatment of Graves, which is what the question is asking for. Next, I wanted to eliminate C, which is long-term methimazole therapy throughout pregnancy. Methimazole is teratogenic in the first trimester. Um, the high yield association you want to know for STEP is aplasia cutis. PTU is actually preferred in the first trimester if an antithyroid drug is needed. And also, the question stem asks for definitive therapy, and antithyroid drugs are not exactly definitive. But the key thing here is recognizing that methimazole is teratogenic in the first trimester. Then I wanted to eliminate A, which is radioactive iodine ablation followed by levothyroxine replacement after achieving hypothyroidism. This is actually contraindicated if pregnancy is planned or possible soon because the radioiodine crosses the placenta and is teratogenic to the fetus. And since this patient wants to be pregnant soon, she would have to delay pregnancy even more if she chooses this route. So the correct answer is B, total thyroidectomy with perioperative stabilization using thionamide and iodine. So this is a definitive therapy that allows prompt resolution and avoids fetal radiation. And if she undergoes this route and undergoes surgery, she has to be rendered euthyroid first using medications. And basically, a total thyroidectomy is definitive and compatible with future pregnancy, given that she'll have replacement with levothyroxine. So, question number two. A 21-year-old man presents after a motor vehicle collision with multiple fractures. He receives high-dose glucocorticoids and is noted to have low T3, normal T4, and normal TSH on labs obtained the next day. He is hemodynamically stable but has prolonged recovery from anesthesia and shows delayed mental responsiveness. Which explanation best fits the lab pattern? So again, noting the keywords or key lab values here, it's mainly the low T3, normal T4, and normal TSH. First, I want to eliminate E, autoimmune Hashimoto flare. Hashimoto's typically causes primary hypothyroidism, which is consistent with a low free T4 and a positive and elevated TSH, which is not consistent with the lab values we have here. Also, Hashimoto's won't present so suddenly a day after trauma, especially in the context of step exams. Next, eliminating D, iodinated contrast from CT scan induced transient hyperthyroidism. So, an iodine load can precipitate hyperthyroidism, which would show high T4, T3, and a low TSH, which again is not seen in the lab values in this question stem. Next, I'm eliminating C, acute thyroid storm. So thyroid storm is a severe hyperthyroid state. So high T3, T4 with low TSH usually will have a lot of hyperthyroid symptoms such as fever, tachycardia, and with this is all inconsistent with the question stem. Next is B, eliminating central hypothyroidism from high steroid use. So central hypothyroidism, if you remember, the problem is um, a low TSH causing a low free T4. And here, that is not consistent with the lab values in this question stem. So the correct answer is A, sick euthyroid syndrome. This usually occurs after acute critical illness or high glucocorticoids. And the thing you want to remember with euthyroid sick syndrome is that it has usually just a low T3. It's because cytokines and stress decrease the peripheral conversion of T4 to T3. So usually T3 will be low, but other labs will usually be normal in the context of USMLE step exams. Moving on to question 3. A 70-year-old woman presents with a rapidly enlarging, hard, painless thyroid mass over 6 weeks and progressive dysphagia. She has a smoking history and weight loss. CT shows a large heterogeneous thyroid mass invading strap muscles and trachea. Biopsy demonstrates pleomorphic cells with frequent mitoses and areas of necrosis. Molecular testing reveals P53 mutation. Which diagnosis is most likely? So again, identifying keywords here. Identifying that the mass is hard and painless is important because some thyroid masses will present painfully. She also has a smoking history and weight loss. I'm thinking cancer here, possibly, and especially with the histology, the pleomorphic cells with frequent mitoses and areas of necrosis, and with the P53 mutation, all point to cancer. So I have these notes written down here up top. So the key thing is recognizing different types of thyroid cancer and how to differentiate them using keywords. So first, I want to eliminate B, Rydell thyroiditis. This is a fibrous replacement, and it also has a hard thyroid, as seen in this question stem. However, the histology would be more consistent with fibrosis and inflammation, not cancerous with the pleomorphic malignant cells and necroses. And Rydell's is more benign and more chronic. Next, I want to eliminate C, papillary thyroid carcinoma. Usually the histology for this would be the orphan Annie nuclei, which look like the orphan Annie eyes from the cartoon, and also the Simoma bodies, which are these concentric circles. And usually this has an excellent prognosis and it's not aggressive, the aggressive pleomorphic picture seen here. Next, I want to eliminate D, medullary thyroid carcinoma. This arises from the parafollicular C cells and would have calcitonin elevation, and usually the histology will say that it has amyloid stroma or calcitonin positivity. Lastly, I'm going to eliminate E, follicular carcinoma. This is less aggressive and usually shows a capsular and vascular invasion, but it's not as rapidly invasive and necrotic as seen in this question set. So the correct answer is anaplastic thyroid carcinoma. This is consistent with the highly mitotic necrotic tumor cells and P53 mutation. It has a very poor prognosis. So knowing the differences between all the thyroid cancers and their histology is very high yield for STEP.